First, I will perform hand hygiene and gain consent from the patient. And then I'll proceed to doing a general inspection of the patient by checking the appearance of the patient and to check if the patient is not confused by doing a mini mental status on this patient by checking for orientation, if the patient is oriented to place, person, and time. And then I'm also checking to see if the patient is not using any accessory muscles like the sternocleidomastoid muscle that is indicative of breathing discomfort. And then I will now check the conjunctiva of this patient, checking for any central pallor in this patient or central cyanosis rather, which is showing any bluish discoloration, and that's indicative of anemia. And also checking for jaundice, which would show yellowing of the sclera, and the xanthelasma for fat deposition, and caesar flexure ring, which suggests copper deposition in the case of Wilson disease. And then I'll check the mouth of the patient. I'm checking for any bluish discoloration, checking for any glossitis and any angular stomatitis, and even mouth ulcer. The angular stomatitis is kind of like crack in the side of the mouth, and that's indicative of vitamin B12 deficiency and dehydration. I'll ask the patient to raise his hand, arm, right underarm, and then I'm checking for any excessive darkening in this patient, which is indicative of acanthosis nigricans, which is showing, which will tell me if there's any gastric tumor in this patient. And then now I'll be doing a clubbing on this patient, checking for any clubbing rather on this patient. Normal is supposed to be 160 degrees. If it's more than that, it's indicative of any liver cirrhosis. I'm also checking for any leukonychia that's indicative of liver failure, and only spooning of the nail bed for any iron deficiency. I'm checking for edema on this patient as well, which is indicative of right-sided heart failure, and the vitreous lymph node, which is indicative of gastric tumor in this patient. First, I warm up my stethoscope. I'll check for the contour of the abdomen, and also check for any dilated vein in the case of caput medusa, and also for any inferior vena cava obstruction or any increased peristatic wave, which is indicative of intestinal obstruction. I'll check for any rashes or any ecchymosis by checking the grain tunnel sign and the Cullen sign for retroperitoneal hemorrhage. Also checking for striae and the scar, and also for checking for any umbilical deviation in this patient. I will warm up the stethoscope, place the diaphragm of my stethoscope at the right lower quadrant, and then I will listen at each quadrant for 1 minute. I will listen for the bowel sound and note the character and the frequency. Normal bowel sound consists of clicks and gurgles occurring every 5 to 10 seconds. I'll also listen for any borborygmi, which is a long, prolonged gurgles of peristalsis from stomach gurgling, and or any form of increased bowel sound, which is indicative of diarrhea or acute intestinal obstruction. And after 2 minutes, I'll listen for the bowel sound. If I cannot hear any bowel sound, that might be indicative of paralytic ileus and peritonitis. I will auscultate for bruit. A bruit is a whooshing sound. I will use the diaphragm of my stethoscope to be able to capture a larger portion. I would first listen to the aorta bruit, which is 2 inches above the umbilicus region, and then move 2 centimeters laterally to the umbilicus, listening for the right and the left renal artery. A presence of bruit on systolic and diastolic is indicative of renal artery stenosis. And then inferior to the umbilicus, I will listen for iliac artery bruit, and at the mid-inguinal ligament, I should be able to listen for the femoral artery. A bruit in systolic is normal, and bruit in systolic and diastolic is indicative of partial arterial occlusion. I'll be performing a peritoneal friction rub. I'll ask the patient to breathe in and out through the mouth, and then auscultate the right upper quadrant for liver tumor and gonococcal infection, and then also auscultate the left upper quadrant for splenic infection. I'll then listen for any granting sign, as in the case of inflamed peritoneum or in the recent liver biopsy. I'll be auscultating for venous hum by listening at the umbilical area, and I'll be listening for any soft humming noises with systolic and diastolic components, which indicates increased collateral circulation between portal and systemic venous system, as in the case of hepatic cirrhosis. Succussion splash. I'll use one hand to place down the stethoscope and hold the abdomen in position. I'll use the other hand to shake the patient's abdomen side to side. A sloshing sound indicates gastric outlets or colon cancer. Percussion of the abdomen in all four quadrants, moving clockwise, starting from the right lower quadrant, which is tympanic, right upper quadrant, which is dull note, left upper quadrant, which is tympanic, and left lower quadrant is tympanic. A scattered dull note is indicative of chronic constipation or intestinal obstruction. Light palpation of the abdomen, I would flex the knee of the patient to relax the abdominal muscle and ask the patient to breathe in and out through the mouth, and I will gently feel in a circular motion for tenderness, superficial mass, or any muscular resistance which might be indicative of peritonitis or inflamed gallbladder. Deep abdominal palpation, I'll be using both hands to palpate for masses, as in the case of colon cancer or distended bladder. I will note the size, the consistency, the tenderness, mobility, and pulsation if there's any mass present. Percussion of the liver span. I will start from the mid-clavicular line and then work my way through from second intercostal spaces until resonance changes to dullness because of the presence of the liver. And then I'll take permission from the patient to mark the spot, and that's where there's dullness. And then, starting from the lower part of the umbilicals, I would also begin to percuss until tympanic changes to dullness to get the lower span of the liver. Take permission from the patient again, and then now do a measurement of the liver span. And normal is supposed to be from 6 centimeter to 12 centimeter. If it's more than 12 centimeter, then in the case of hepatomegaly, and if it's lesser than 6 centimeter, in the case of liver cirrhosis. Palpation of the liver, I'll place my left hand at the 11th or 12th rib on the right side of the patient, and then place my right hand lateral to the rectus muscle. Ask the patient to take a deep breath, and I'll then feel for the liver edges, feeling for the smoothness, the sharpness, and the softness of the liver. Any irregular liver is indicative of malignancy and tenderness, hepatitis. Percussion of the spleen, I'll start my landmarking from the suprasternal notch and then move down to the suprasternal angle, mid-clavicular line to the second rib, and then down all the way to the 6th rib. My target is to get at the tropic space, which superiorly is the 6th rib is present, and then laterally to that is the anterior axillary and left costal margin medially. And then I would try to listen for percuss for tympanic sound. Any dullness is indicative of splenomegaly or colonic cancer. I would support and lift the left lower ridge cage with the left hand while patient is in supine position. Ask the patient to take a deep breath, and I'll palpate in a circular motion from the right lower quadrant diagonally to the left costal margin. And then I'll try to palpate for any spleen. And normally it's not supposed to be palpable if it's palpable in the case of splenomegaly. Place the left hand on the back of the patient just below the 12th rib, and then the right hand upward. I'll ask the patient to take a deep breath, and starting from the right upper quadrant by capturing the kidney between both hands, I'll be feeling for any tenderness, and it should not be palpable if it's palpable in the case of hydronephrosis or polycystic kidney. Examination of the aorta. Press down deeply, slightly left of the midline above the umbilicals with one hand on each side of the aorta. Identify the aortic pulsation. Easily felt on most individuals. A well-defined pulsatile mass greater than 3 centimeters across suggests an aortic aneurysm or that is caused by atherosclerosis. Percussion for ascites. By doing a shifting dullness, I'll determine the border between tympani and dullness in supine position. And I'll be marking on the patient. And then I'll place the patient in lateral position. I'll make sure to see if there's any changes in lateral position. In ascites, dullness shifts to the more dependent side, while tympani shifts to the top. Checking for appendicitis at the Mark-Bonney point, I will start from the anterior superior iliac spine and then draw a straight line down to the umbilicus. And 1/3 lateral to that point, I will be looking for any rebound tenderness that might be positive of appendicitis. Using the psoas sign, I ask the patient to resist against my hand. And then if there's any tenderness, it might be indicative of appendicitis. I'll do the obturator sign by internally rotate the leg of the patient and feeling for any tenderness indicative of inflamed appendix. I'll be eliciting for the fluid wave. I'll ask the patient to place his hand on the midline and then tap on one side of the abdomen and then check the opposite side for any impulses. Kidney costovertebral angle tenderness. I ask the patient to sit up, place one hand over the costovertebral angle and with my hand at the 12th rib, and I'll strike gently with the ulnar surface of my fist, and then if there's any pain, it's suggestive of pyelonephritis. End of the examination, I'll perform an eye hygiene and take the patient and ask if patient have any question for me, and then take all the findings to Dr. Ninam to see what we're going to be doing, and also refer the patient to Dr. Cowboy for ophthalmology consult as well. Thank you for watching.